and longitudinal monitoring if AI-enabled care is to be safe, effective, and fair. And whilst we hear a lot about that, operationalizing those needs is far from straightforward. And that's what we're going to be digging into today with our guest speaker, Harris Shuaib. Now, Harris is CEO at Newton's Tree. He's co-chair of the Medical Open Network for Artificial Intelligence, and he's director of the NHS Fellowship in Clinical AI. So if I could invite you to join us, Harris, and it's great. We've already got the slides up here, so the title we can see there, hearing about AI platforms in testing and monitoring in healthcare. So thanks very much for agreeing to join us, and I'll hand over to you.
Amazing. Thanks, Jeff. Appreciate the introduction and hi, folks. Thanks for joining today. So I'm going to be talking about really what it says on the slide, from black box to glass box. What is the role of AI platforms in testing and monitoring in healthcare AI? And obviously, I have a pretty big vested interest in this space, but very keen for this to be an educational session, and so very happy for people to fire away in terms of questions in the chat or the Q&A section. If you want me to cover certain things, I don't want to dwell too much on my slides. I'd rather hear about the things that are on your mind. But I'm going to start with sort of laying out the landscape and sort of where we are today. Because for those of you who come from a medical imaging background like myself, so I'm a medical physicist by background, AI has been around for almost a decade now. So it's not something that was invented post ChatGPT. It's something we've been using clinically for about that long. But if you think about what the market looks like today, we're absolutely inundated with AI models, and there's more and more. I was about to say every year, but it's almost like every quarter these days. And there's obviously no shortage of demand from the hospital end. Most of you on this call are sitting within the healthcare system, desperately interested to see how AI can help deliver better services and more efficient services as well. But the reality is that most NHS hospitals in particular have very few AI algorithms being used live in a clinical environment. There's probably lots of pilots, lots of evaluation studies. I've been chief investigator of a few trials, but how many things have become bread and butter clinical practice? And the reality is it's very little. And so I describe this as a market failure, right? Because you've got so much demand and you've got so much supply, but it doesn't seem to be meeting. And in my opinion, the reason the market is failing is for, some traditional reasons that markets fail. So the first one actually is, there's a real vendor exhaustion that is perceptible from within the healthcare system, right? We've had, like, being from within the healthcare system, vendors knocking on our doors for, like I said, a decade, with lots of promises, but very little impact. And it becomes increasingly challenging the more and more vendors that flood the market with very, very similar products. The second challenge is one of information, is that often buyers, whether you're clinical or operational, do not have enough information to confidently make buying decisions. So there's a real sort of lack of evidence. Again, that's trending in the right direction, in that there are more trials, whether they and service evaluations, whether they were funded by the AI Award or AIDF and other sort of government funding initiatives. The evidence base is building, but I will still obviously highlight that no medical AI technology has NICE approval. So no AI technology has proven the cost effectiveness question in England, at least, or in the UK. And then one of the final challenges is around implementation. the NHS is famous for having relatively outdated technical infrastructure. And what that means is that we do not have a particularly agile digital estate, which means integrating these cutting edge digital technologies is a pain in the butt, to put it frankly. And not just from a time and effort perspective, but also from a cost perspective. And so often you'll see project costs that are greater than the cost of the AI license itself. You know, an AI license might cost you £100,000, but the cost of implementing that license costs you another £100,000. And so all of those things conspire to really putting the brakes on AI adoption. And the chart that you see on the bottom around is the annual approvals and the FDA granted of medical AI software. And you can see how it's increasing year on year. None of those, because those are numbers up to 2024, include language model technologies. So that avalanche is yet to come. And we've just started to see some of the first LLM-based technologies get market approval. And so the challenge is this is what you're faced with as a health system, is lots of logos covering every inch of the hospital increasingly. The top left is the category for ambient scribes. The screenshot you can see is slightly out of date because it says there's 79 ambient scribe vendors. There's well over 100, and there's no sign of that slowing down as more and more digital health vendors and health IT companies decide to build their own ambient scribes, given how easy it's become. And so one of the first challenges you have when we're talking about turning that black box into a glass box is having sort of open standards to evaluate these technologies and their evidence base. So one of the first things that we set out to do at Newton's Tree was just to catalog all of these applications. So we've painstakingly gone through each one of these applications and catalog things like not just their sort of market approval, but also published clinical evidence, training population data, and even private data that we have access to as a platform vendor, so that ultimately we can help clarify the field for our hospital partners when they are looking to shortlist vendors. Because on the face of it, before you even get to the technology, the marketing material acts as a black box. And we need sort of efficient tools and standards through which we can compare vendors to each other in an objective and transparent way. And so that's actually one of the first steps. And people forget how writing really clear tender specifications or reporting standards begins to open up that black box around AI performance and safety. And one of the really positive steps in this direction that happened recently, although I know it received sort of mixed reviews from people in the system, was the letter that NHS England published around ambient scribes. It provided a bit of clarity around the standards and requirements that ambient scribe vendors need to meet in order to be used clinically in the NHS. And so efforts like that shouldn't be underplayed or underweighted in how effective they can be in helping keep products safe and effective. The challenge, though, is even if you have something like that, the reality is that there aren't any regulatory requirements for vendors to publish publicly information on safety and efficacy. Most of it is considered sort of intellectual property or sensitive commercial information. It's submitted to the regulator or to notified bodies, but there's no requirement to publish any of that information publicly. And so this is a graph from a survey conducted by a group in Stanford, which then showed that actually most of them don't therefore share information publicly around safety and efficacy. And so that creates a lot of risk around the performance of these AI models, because even if you have, that letter from NHS England saying, ambient scribes need to be at least class 1, and they need to meet these sort of cybersecurity standards, et cetera, et cetera, et cetera. You still don't actually know how it's going to perform in your population, right? Because, say, for example, you're a pediatric hospital. Um, there's nothing that is out there in the public domain that can give you confidence on how this is going to perform when you're conducting consultations with parents and children in the room, with multiple voices, with different kinds of voices, etc. And because you can't compel vendors to share that necessarily, it then creates this requirement for the hospital, or whoever the buyer is, to verify performance before they commit to a vendor. And that's what I would consider sort of step two in transforming that black box to glass box. So if step one was about objective and open requirements and standards around reporting, the second step is then empirical performance data. And so one of the things that we set out to do to support our hospital customers was to give them access to tooling to verify performance and gather feedback of, in this instance, ambient scribes, but really any AI technology, using their own patients' data and their own physicians' feedback. So this, you can see sort of a screenshot from a prototype of our ambient scribe evaluation screen that allows hospitals to basically work through consultations and basically annotate or evaluate the accuracy of the performance of the scribe. And this again begins to help you as a buyer or as a decision maker inside the hospital understand the value and performance you're going to get out of this product, versus just having the tender specification or these sort of objective criteria around market approvals and things like that. And so, oh, and this is essentially just a summary of what I've just said. And the really interesting thing is when you have such a capability as a health system, not only can you do that with a given product, but actually you could do that with multiple products in parallel. So, for example, you see that work list that I've kind of covered. Let me go back on the left-hand side, which is a consultation. Each one of those is a consultation. Like those could come from different scribe vendors, and it's allowing you to do head-to-head comparisons, potentially as part of a procurement process. And so this is another way that AI infrastructure companies or AI platforms can help hospitals understand better the value and safety of these tools. The final challenge then comes, oh, it's probably not the final challenge, but one of the final challenges is around implementation. And it's no secret that IT departments do not have spare capacity, and that's just a reality of the state that we're in. Not just in the UK. This is probably common across different health economies, and it's not unheard of to hear about time to deployment taking 6 to 18 months post contract signing. So you've committed, to do a project or to implement a technology. You're then suddenly waiting 6 to 18 months to deploy, and this creates all sorts of problems and risks. Aside from the fact that your time to value is incredibly lengthened, the technology moves incredibly fast. And so if you're taking a year or 18 months to deploy something, it's very likely that the technology that you've selected is no longer the best technology. And also the testing and evaluation that you've done is less relevant. And in the extreme scenario is not relevant at all, because there's been a shift in, I don't know, the clinical workflow, the population, some other sort of domain shift has occurred. And that's really where, when we talk about platforms, where they come to the fore, where they essentially act as this sort of IT orchestrator for algorithms that should allow you to very quickly, and when I say very quickly, I mean within minutes, turn on AI applications, and be able to integrate them within live clinical workflows. But what does that mean when we say going live? So there's different levels to the support that an AI platform can deliver in order to make things easier for enterprise IT teams. So the very basic one is hosting. So if you're deploying an AI application, platforms should be able to host those applications, which means you do not have extra requirements around hardware or extra cloud costs and things like that. It should also cover integration with your EHR or your PACS or your LIMS system. That becomes critical and often is the biggest source of delay. The orchestration component is what takes care of the embedding within the workflow. Because what you want is when you say sit down to review a case, you don't want to then wait for an AI result. As soon as you open a patient file or a patient case, you want the AI result to be there immediately. And that's what the orchestration should take care of. And then the final component is monitoring. And I've got some specific slides to talk through around the work we do around monitoring. But overall, that gives you an idea of how a platform can begin to help you uncover some of the hidden risks around adopting AI technology and go from that sort of black box to glass box. But I promise to go deeper in monitoring because this is actually a very rich conversation and topic that is relatively unscratched in this field. So the first thing I'll say is that ultimately the purpose of all of this is to deliver better healthcare, right? And we already have our well-established principles of clinical governance inside the National Health Service of how you're supposed to deliver good quality healthcare. And I'm a big fan of not reinventing things or setting up new structures and concepts and slogans. And I see monitoring of AI very much fitting within this existing framework of audit and risk management and clinical effectiveness. And so we set off to do a very specific project to see how we could help health systems meet their clinical governance requirements. And in order to set the scene, I'll just give a bit of background first. So the first thing to say is that if you've ever been involved in doing the clinical safety case as a clinical safety officer of a diagnostic AI technology, you know that actually most of your risks boil down to two main issues, overdiagnosis and underdiagnosis. Those are the main hazardous scenarios that you're trying to avoid. And then if you look at the causes and effects that lead to those situations arising, again, they boil down to sort of three core areas. One is your input data quality. The second one is any changes to the AI application. So this could be sort of version upgrades or some other kind of change or shift. And the third one is a change in human behavior. And this is often manifested in either over-reliance in AI, so automation bias, or under-reliance or over-skepticism, where people will ignore the AI result. And the challenges with these causes is that it's very difficult for a hospital to independently implement mitigations. And the typical mitigation with a lot of these things, particularly with things like data quality, is, oh, there's a human in the loop. They will be able to make sure that the data is okay. But I just want to show you this example, which a lot of you will have seen because it's from a very famous paper in 2019 from MIT around how actually humans in the AI world are not effective quality control mechanisms. So you have in the left-hand side an original dermatoscopic image of a benign lesion, right? And below the image, you've got an AI prediction. And the AI has correctly predicted this lesion as benign with 100% confidence. So you're like, great, this is going well. The algorithm has got it correct. Now, if I was to tamper with this image on purpose and add a bit of a noise that you can see in the middle to create the image on the right-hand side, now the thing to say here is that image on the right-hand side is imperceptibly different to the image on the left. A dermatologist cannot tell the difference between those two images. However, for the AI, there is some difference because now that same AI algorithm considers this same lesion as malignant with just as much confidence. Now, the issue here is that a dermatologist cannot act as quality control on the data here because the human eye cannot tell the difference between those two images. And the reality is that things will change. Like if anything is true in the world or in healthcare, is that things change. And so no matter what you do, for example, in your pre-deployment evaluation, like the example I gave you with the ambient scribes, it does not necessarily reflect what is going to happen in the real world. Or at least it might not reflect the real world after a certain period of time. And like I mentioned, the world changes, patient demographics change, equipment gets upgraded, clinical workloads change, and all of that leads to potentially silent failures, exacerbation of bias, and ultimately patient harm. And I'm just going to give an example of over-reliance and how that can manifest itself. So this is from a paper. Oh, I should have included the reference. I can send it around for people who are interested. So what you can see here is the performance of radiologists when they are given the correct suggestion by the AI versus when they're purposely given the wrong suggestion by the AI. And it's broken down by experience of reader. So the first thing to say is if you look at the first triplet of bars, so the first 3 bars, that is when the AI gives you the correct BI-RADS score when looking at mammograms. And you can see here that all 3 groups of radiologists, whether they're inexperienced, moderately experienced, or very experienced, all have very similar average performance, which is great, right? That's the whole promise of AI, is that it reduces unwarranted variation of care. So you're like, hey, it doesn't matter how experienced the doctor is, the AI is going to make sure that they all have decent performance. But when the AI is wrong, then the picture is different. Now there is not uniformity across the different staff groups, right? The very experienced radiologist on the far right, the gray bar, has a significant drop in performance from 80% on average to 40%. However, the other groups are even worse, right? The moderately experienced is just above 20%, and the inexperienced radiologist is barely at 20%. And so this becomes very interesting because when you're doing your product evaluations as part of a procurement process, and you're using, for example, your most senior doctors to evaluate performance, that's not going to translate across your entire department. And also potentially not taking into account this time varying effect around over reliance. The challenge, though, is we know that there is an overwhelming pressure in the National Health Service to do more with less resources. And so AI is an inevitability, right? And this is a screenshot from an old Twitter post now. I think this potentially during the pandemic that went sort of viral for all the wrong reasons. But I've just sort of highlighted the interesting bit where obviously some senior doctor is asking SHOs to bulk do discharge letters, giving them the grace of 3 to 5 minutes per letter. And if anyone's been involved in writing discharge letters, you know that you cannot do 60 at a rate of 3 minutes per letter. But this is sort of the reality that is that the front line is being faced with. And so for all of those reasons, we set about to figure out how, as a platform, we could help hospitals mitigate some of these risks and build confidence in AI post-deployment. We also recognize that this is actually a really good opportunity, this post-deployment monitoring, to feed back to vendors so that they can build better products. Because if it becomes easy for us to detect when the AI is not performing well, then we should be able to close that feedback loop. And then ultimately, we want to end up in a place where we have this sort of learning health system that we've been sort of banging on about for decades. And And so what we've built at Newton's Tree is something called FAMOUS, which stands for Federated AI Monitoring Service. And it monitors the data that you see on screen is junk data, so don't read too much into it, but it monitors the three things that are highlighted when discussing the clinical safety case, which is input data quality on the right-hand side, which is done through an outlier detection algorithm, then AI prediction behavior changes, which is done at the top left, around, it's called AI inference values. And then over-reliance and under-reliance is done at the bottom left in the chart labeled AI human agreement. So we monitor these things, or are able to monitor these things in real time. And we had some funding from Innovate UK to validate this in an NHS environment, and we're very happy to collaborate with Glasgow and Leeds teaching hospitals to see if something like this could be useful in practice. And so one of the first things we did was look at whether we could detect outlier input data quality. So some of this analysis is still in progress, but we did some ad hoc analysis with some of the leads data where you can see some very clear outliers, and we're able to pick up with 100% positive predictive value outlier chest x-rays. Every time we opened one of these outliers, there was something wrong with the image. Patient had a pacemaker, they were wearing a necklace, the projection was incorrect. All of those issues that would trip up an AI algorithm. The other thing that we looked at was agreement between the AI and the radiologist. And what we were able to observe, and we tested this with different AI applications as well, what we were able to observe was a week-on-week increase in the agreement with the AI algorithm. I actually have a chart splitting this out between Leeds and Glasgow. I actually don't have it on the screen, which showed that actually in Leeds, there was no increase in agreement over time, whereas in Glasgow, there was. And there's all sorts of reasons that could contribute to that, skill mix, time pressure, etc. But the important thing is that we were able to detect such a pattern of behavior, and theoretically could then flag it back to the site to highlight the fact that this over-reliance was occurring, particularly in comparison to a different site. So I hope that that's given you an overview of how much heavy lifting an AI platform can do, as well as the technical and non-technical services that help bring us more transparency in our adoption lifecycle. And so I'll just leave you with this slide to say thanks to the folks who are particularly involved in the FAMOUS study, as well as partners in more general. I'll stop sharing now and happy to take questions.
Thanks for a brilliant talk, Harris. That's fantastic. I can see we've already got one question come in, and I'll come to you one by one with the questions and try and unmute you so you can speak to your own questions, just as a little heads up. But before we do that, I just wanted to ask, Harris, that monitoring function, is there a way in which that can be used just for kind of monitoring real time, the kind of standard of care as is? Because something I've noticed with AI implementation, the potential of return on investment is really dependent on baseline performance, which varies a surprising amount for particular KPIs between providers. And it seems like there's quite a big value proposition there. One, in detecting what kind of solution might be most valuable at a trust, but then also in a sort of general QI function for a healthcare provider.
Yeah, very good question. And because you have to close not just the safety loop, but also the value for money loop. And so, yes, the short answer is obviously there are some value or some KPIs which are easier to measure. So if we were to stay in the diagnostic sphere, then say, for example, report turnaround time, that's something that's very trivial for us to calculate. as in, from when the image was acquired, when was the final report created? And, does AI speed up report creation and therefore theoretically patient turnaround? That's very easy to measure. If your KPI is, outcome based or something else, like, does this lead to faster time to treatment or better treatment outcomes? That becomes more challenging for all the reasons you're probably aware of, the challenge of getting this sort of outcome data. But definitely, like, a lot of the operational metrics should be part of this solution.
Oh, that's really interesting to hear. Thanks. So next, I'm going to go to some of the questions which are rapidly expanding. But Marlene, I've just unmuted you, so hopefully you'll be able to speak to your question. I'll just hand over to you.
Hi. Yeah. Well, my question was on the AI scribes and the medical device classification as class 1. But class 1 really requires only a self-assessment, and that's not audited. So I was wondering if it would be good to have an audit process in place, of course, by the MHRA, and especially looking at safety and things like that, considering the risks involved with these scribes.
So good question. Yeah, possibly. There's other ramifications in changing the requirements for class 1 medical devices, which make it a much more nuanced or a much more challenging thing to propose. Absent any changes at the regulator end, it just reinforces the need for healthcare buyers, hospitals, to have these independent processes. Because ultimately, if a product has market approval, it's ready to be sold rather, and it's on the buyer to make sure that it's safe and effective for their context. And also, given that the performance of AI technology can be hyper-local, increasing sort of external audit really only has limited impact in actually de-risking the technology. Yeah, I mean, you can look through all sorts of reports. It doesn't actually prove how well this technology will work at, St. Thomas's or in Lewisham or in Birmingham until you actually use it in Birmingham and Lewisham and St. Thomas's.
Yeah, that's true. Yeah, generalizability is quite important. Thank you.
Thanks.
Thanks very much. And next, Ben Wilson has put a question in the chat. If I could hand over to you, Ben, I think you're unmuted.
Hi, yes, thanks very much, Harris, for the talk. Really interesting to hear. So my question is basically that the monitoring task you've made very clear is really significant. So would you argue that the benefits from any deployment can only confidently be realized if the organization hosting the deployment has a competent clinical intelligence unit? For a description of that, I would describe it as a clinical data science function. Maybe I'll stop there. That's the question, and I've got further things to perhaps probe if there's time.
So Ben, in short, yes, and I say this from a very biased perspective because I used to be the head of the scientific computing team at St. Thomas's, which you could probably describe as sort of the clinical data science function. And it's a pattern which is common with other advanced technologies. We have in some hospitals massive medical physics and clinical engineering teams who exist solely for the safe and effective use of dangerous and complicated technology like linear accelerator, right, like radionuclides. And I think with some AI technology, it demands a similar kind of local expertise. Obviously, that won't necessarily exist in every sort of district general hospital. And so there is a system demand to make sure that there is enough coverage. And so that clinical data science team might not sit literally in your hospital building. They might be in your neighboring teaching hospital or somehow or other available to you. But I think it's inevitable.
Thanks very much.
Follow up, Ben, if you wanted. Yeah, great.
Yeah, it felt as though the hyperlocal that you described before, what would work at Guy's and St Thomas, what would work in Birmingham, you can't tell until you're there, is also true of what you know about. I mean, I think the evidence you presented in relation to Leeds and Glasgow is always going to be interesting, because how humans respond is critical, rather than whether the AI itself has got some kind of performance metric that you can isolate. It's the combination of the human and the machine, as opposed to what the machine can do.
Yes, exactly. And I would add a third dimension, which is the patient. So it's the sort of skill mix and the clinician and the clinical workflow, the technology, and then the underlying sort of patient and disease population. All of those things sort of commingle to make it a pretty dynamic environment.
Indeed. Great. Okay. Well, I'm not sure of the implication of that for the healthcare economy, because those teams need to be there, and there isn't a history of doing that well in hospital IT.
Thanks very much. Next up, I'm just going to hand over to Jay Liu, who I think I've unmuted.
Hi.
Great.
I just want to understand if you had any insights between private and public healthcare providers. Is there a difference in kind of adoption rates, the type of AIs they like, or how they evaluate the AI in terms of certain priorities? Is there any difference from your experience?
Yes, so good question. So it's hard for me to be definitive about this, particularly in the UK. I've dealt with private providers and NHS, and there's a broad spectrum across both of them. So there's significant overlap. Where there is significant difference is with some of the sort of private providers in the US, where you see a lot of adoption. We're talking about sort of 40, 50 AI technologies being used live clinically. And the rationale there is, or the driver there is the health economic one, right? Because AI technologies are great at picking up things that need further investigation. And in a US style system where you're paid for activity and there's no reason for a hospital to do less, AI technology is fantastic, because it will pick up every suspicious lesion that it thinks needs a biopsy or a CT. And that's a revenue generator for the hospital. Whereas in more socialized healthcare systems like the NHS, we have this downward pressure to save money and be cost effective. And AI is not great at being cost effective, particularly diagnostic AI, because it is a sensitive technology by its nature, whereas humans are far more judicious. And so often it's the health economics that is driving the adoption rate more than anything else.
No, great. That makes sense. Thank you.
Thanks very much. Next, we've got a question from Martin Frenet. If I could hand over to you, Martin.
Thank you. Hi, Harris. Thanks for the presentation. I would like to. I just wanted to ask, but more from a vendor standpoint, how many are prepared for some of the pushback that they get from clinicians as to the risks associated with deployment of their technology? There are standards out there that hopefully some of these companies are able to look at. And could you just touch on, your platform in Newton's Tree, how it can accelerate that process for them?
Yeah, a very good question. So there is a broad spectrum of attitudes, as you might expect from vendors. I think vendors, particularly selling into the NHS, have been burned by pilotitis, right? Which is where this sort of pre-deployment testing goes wrong, where people insist on trying AI algorithms, but in a really non-rigorous fashion, where you're not actually getting to an answer. You're essentially just forever kicking the tires on a technology and not really building a business case or a safety case or wherever it might be. And so vendors now have reacted. Some vendors have reacted quite strongly against the idea of pre-deployment testing. And what we try and do with both sides is give them sort of a glide path and say, hey, look, we think that pre-deployment testing is still important, but it's important for it to be efficient and effective. We're trying this technology because we're trying to improve this KPI, which could be, clinical related or performance or whatever. And the point of this pre-deployment testing, which should be time boxed, is to see if this technology meets this standard. And if it does, great, and we move forward to a commercial contract. And if it doesn't, then let's stop wasting each other's time. And I think once we clarify that process and that discipline, it keeps the vendor much more interested and engaged, and also allows them to participate in a way that reduces their costs. Because when the vendor is involved in having to do the heavy lifting in this pilot world, there's a massive cost burden on them, right? Whereas a platform that acts as a middle layer, it's doing all of the heavy lifting. So from a vendor perspective, they then don't have to suffer those costs either for the sake of some testing.
Does that create an added burden for you, though? In the end, you're sort of trying to provide the answers for the buyer.
It does, yeah. So
Or-
it means the platform is doing the heavy lifting ultimately. And so what becomes important then is, what is the platform's business model? So why would an AI platform do all of this work? And so the way that Newton's tree works, but others can work differently, is on a success fee basis with the vendor, right? And so if the hospital ends up buying a certain technology, we then take a percentage from the vendor's contract, much like a procurement framework would. And that then sort of aligns our incentive with the health system, because we're not charging the health system for this work, and we're only charging the vendor on success. So it's sort of a win-win, but obviously it creates risk on the platform provider.
Great, thanks very much. Next, I'll come to Mark Jones, who I'm just seeing if I can unmute. I think
I am.
Mark, can you talk already? Sorry.
Yeah, can you hear me?
I fluffed that. Yep, you've done
Yeah,
really well.
cool.
Thanks very much.
Harris, hi. Thank you very much for the talk, really enlightening. I'm coming to this from an actual commercial organisation that are trying to get our products used in the NHS in the UK. What's your thought about the reimbursement of products, and how do you think that's going to change over the next couple of years?
Oh, very good question. It's like the question. How do we get paid?
It's my favourite question. I need an answer.
Yeah. So there's sort of like three ways that I sort of slice this, at least for the UK NHS. So one is sort of grant funding, and I would count like the AIDF, AI Diagnostic Fund, the AI Lab. These are the sort of like parachuted in money as sort of grant funding. It's not BAU funding. And then you have national sort of commissioning, so that sort of NICE approval, NHS England budgets, and then you have departmental expenditure. And what I advise both hospitals and vendors is to ignore the first two, because they are at best distracting and at worst can kill a business. I think what is much more practical in the short term is you talk to a departmental budget holder, whether it's, the director of radiology, the director of pathology, some ops manager who has a cost burden, whether it's, I don't know, agency spend, outsourcing of scans, penalties and fines. And then you figure out, how do I make a budget impact analysis to demonstrate to this budget holder that I will save them money in year?
Yeah.
And that's the first thing that you should be trying to do in any commercial conversation. Is you talk to the budget holder, you identify their costs that you can avoid, and how do I help them avoid it in year? And that's the most productive conversation to be having today. That's not to say that you don't take grant money, or that you don't work towards NICE approval, but it's just a long and treacherous journey.
If you can demonstrate like some added value in a local hospital, would you go to the ICBs as well and look at maybe kind of funding this across 5 or 6 ophthalmic departments and under their care as well eventually?
I mean, you can try, but it's just very difficult in the current economic climate to ask for an increase in expenditure for value or quality. It's very hard. to do that in this and the next financial year. That's not to say that it won't happen. Like, all of this is just like about risk based approaches. The lowest risk approach is around cash releasing and cost saving in year.
Yeah.
Yeah.
Wonderful. Yeah. Thank you so much. Cheers.
Thanks, Mark. Good question.
Thanks, Mark. Next, I've got Nigel Davies with a question. If you could come in, Nigel, and speak to it, that'd be great.
Hi, thanks. Yeah, so my question was about you talked about the long time lag in deployment of AI tools and the issues with like the rapid development of technology, and your things becoming less relevant over time. Does that not point to like a deeper problem with the adoption of AI tools, in that there's the investment required is so great in order to do the evaluation, but the risks are also really high because you don't know whether next year this tool is going to be obsolete or it's going to be surpassed by something else, and then you're going to have to invest again to evaluate that one.
Yes, yeah, you're exactly right. Like, because when you take into account sort of the total cost of ownership, it really blunts the business case. Because if you say, like, I'm going to have this infrastructure, we talked about having a local data science team, all this sort of data curation for testing and all this sort of monitoring framework, and then you're like, where is the saving anymore? I think that's a very real challenge and consideration. It also means that some use cases, especially in the near term when we don't have luxury for cash, just are not viable because it's too small, a patient population, or too small a value proposition. However, the thing, and this is where my very biased opinion is, that you need your infrastructure to do the heavy lifting. Your EHR vendor, an AI platform, whoever, should be making this much, much easier, right? So in some of the work that we've done with some of our hospital customers, we've been able to execute, for example, that procurement and head-to-head testing in a matter of weeks. And when you can do that in a matter of weeks to pick a new product, then the fact that you might have to pick another one in a year's time is slightly less daunting and less of a concern around sunk costs. Obviously, if it takes you 6 months to run a procurement process to then procure something for a year, then it's a non-starter. Yeah.
Thanks, Harrison. Thanks for the great question. The next one, Zoom has served up without a name attached, I'm afraid, so you're going to have to put up with me reading it. But what recommendations do you have around the education required at point of deployment and then post-market surveillance? Does Famous highlight specific individuals who perhaps have educational or development needs?
Yeah, like another very good and very tricky question. So, it's a lot of overlap with the data science unit sort of idea, in that, like, as an example, so my background is as an MRI physicist. That's how I started my career. And a part of my job was analyzing and doing the quality assurance of MRI machines on a sort of an annual basis or something like that. And I think, yeah, in order to do this post-market monitoring or post-deployment monitoring, you're going to need to have similarly sort of niche skilled people for that post-deployment monitoring to be feasible or doable. But the challenge is that there's been no investment in developing local capacity and capability. So, this is where the challenge around grants come, right? So, things like the AI Diagnostic Fund did great in promoting the use of chest X-ray across the system, did not do anything around capacity building, or like almost nothing, right? So you have 50 or 60 trusts now, I think, that are using chest X-ray AI technology. Thanks to the AI Diagnostic Fund, you do not have 50 or 60 experts in how to monitor chest X-ray AI. And that's a real shame, because those same experts could have been used for the next project and the next project. And so it's going to require very significant investment. One of the things that, and Jeff mentioned it at the beginning, that I do that's related to education is the fellowship in clinical AI. And that's aimed at resident doctors and other sort of mid-career healthcare professionals, but it's really just a drop in the ocean. We're just about to do cohort 4, which is going to be, I think, 30 odd doctors or 30 odd healthcare professionals. There needs to be much more than that in terms of investment in local capacity and capability for testing and monitoring these products.
Thanks, Harris. Great answer. And a tricky and important question, as you say. We'll drop the link to the fellowship in the chat as well, because there's people interested. And final question from Amanda Penny. If we have time, I might squeak one in, but we're coming up to the end. So Amanda, the floor is yours. I think I've just unmuted you, hopefully.
Thank you. Thank you very much. Can you hear me?
Yeah.
Yeah. That was really, really insightful, really interesting talk. Thank you. And I'll share that with some of the founders that I'm working with. But I just wanted to ask you, what's your take on the role of and the future of innovation passports, please, particularly within the 10-year NHS plan?
I don't know, to be honest. I don't quite know what they are. It's not obvious to me how they work, because until you remove responsibility at the individual institution end, right? So, for example, and I might be mischaracterizing the innovation passports, but the principle is that you have an innovation that is sort of approved or readily accepted in one location or centrally, and therefore should speed up or smoothen rollout across the country or the system. The challenge is that individual institutions, like Guy's and St. Thomas's, have legal responsibilities around their finances, information governance, etc., etc. And so if I'm expected to pay at St. Thomas's for a technology, does that mean I have no sort of fiduciary duty anymore? Like I don't have to think about value for money anymore. I can just sign off the business case. And if I'm the data protection officer at Guy's and St. Thomas's, does that mean I'm no longer responsible of what happens to my patient data because this company with an innovation passport and their server running under the desk in Vietnam, is that means that it's okay because they've come with a passport? I don't know how this is going to work in practice without removing legal responsibility from individual institutions, and that is a much bigger political challenge that no one is going to touch.
Thank you.
Thanks, Amanda.
Thanks, Amanda.
And just one final question, if I may, just to bring us
on, yeah.
I was really struck by the brilliant visualization about the complexity that the human AI team brings, and how that plays out in a different way in different contexts, time and time again. And I think that kind of decision support use case has that instability with it, which is always going to be a bit of a challenge. And I just wondered, in a kind of future scanning view, how much do you think more autonomous use cases are going to come in? How much is that a desirable state? What the kind of key barriers you see along the way are? I know it's a big question.
Yeah, no, but it's a very good one, right? And it makes me think about self-driving cars. So all of the incidents that I'm aware of, whether it is in clinical decision support systems in the NHS or with self-driving cars, all of the incidents that I'm aware of have always been because of a breakdown between that human AI partnership, right? As in the human was supposed to hold onto the steering wheel, but wasn't, and therefore they crashed, or they were supposed to not be sleeping, but they were, and then they crashed. Or, for example, the radiologist was supposed to independently look at the images, but they didn't, and therefore the patient was misdiagnosed. But the thing is that pattern of behavior is unavoidable, this sort of automation bias. We know this, right? It's a reality of our psychology where once something starts helping us or assisting us, there is a desire to just completely outsource the task to that thing, whether it's a car or a piece of software. And so sometimes I think perhaps the safer thing is to aim for full autonomy, where we say, look, let's avoid this driver assistance, clinical decision support, weird world that we're in at the moment, where liability is very unclear, and it creates a lot of anxiety with a lot of people. And instead, let's just say, look, we're happy to use AI, whether it's driving or in healthcare, when it's fully capable of driving by itself. And we're not here today, and therefore come back to us when it's capable of that level of performance. And once it is, we will outsource the entire task to it. And there will be no confusion, and there'll be no complicated interaction for us to account for. Because just like autopilot, it's being done entirely by the computer. There's no confusion. When autopilot is on, who is flying the plane? And that's what we should aim for. I think that creates other interesting ethical headaches, and also headaches around de-skilling of the workforce. But I think it's a very valid conversation to be having.
Oh, well, thanks for sharing your thoughts on that tricky issue, and for a brilliant talk, as you can tell by all of the questions that have come flooding in. So, yeah, thanks from all of us, Harris. And we're taking a breather at the Incubator over August, over the summer holidays. So I'm going to wish everybody a pleasant summer holiday too, but we'll be back in September with a talk from Jenny Partridge, who's an innovation manager at the Health Innovation Network, Kent, Surrey, Sussex, on Wednesday, the 17th of September. And that's going to be hearing about some ambient voice technology evaluations they've been doing on the ground there in primary care, which I know is something you're plugged into as well, Harris. So really looking forward to that conversation. Thanks again, Harris, for joining us to talk, and thank you everybody for dialing in. Enjoy your evening.
Thanks, Jeff. Bye, guys.